You're good. We don't need it. We're good. We got it. Just sit down and enjoy the people. You're okay. It's all good, Kendall. I'm glad you're here. All right. Welcome, everyone. I'm Lori Ledley from Valley Sleep Center. I'm here with Lori Beather from Inspire. This is Dr. Kelsch with Valley ENT.
Hello.
And tonight we're going to be talking about alternative options to treating obstructive sleep apnea. So it's all you. Thank you.
All right. Well, thank you. Thank you for having me. Thank you to our live audience and to our online audience. I'm Dr. Timothy Kelsch. I'm an ear, nose, and throat surgeon here in Scottsdale. Yeah. I have been practicing in the Valley for about 12 years, and I do quite a broad, comprehensive care of the head and neck, and do quite a bit of head and neck cancer surgery. To say I've done surgeries in this area a lot is an understatement. Inspire, or a hypoglossal nerve stimulator, has been something that's been a big game changer for our industry for many, many years. We've been doing surgeries for sleep apnea to try to open up the airway and improve breathing and snoring, and to sometimes little avail. Sometimes we would hit home runs and sometimes we would not. You know, the essentials of sleep apnea is obstruction, and we're going to get into that in just a second. But today we're going to talk about some of these new advances and how it's really changing some of our alternatives to traditional treatments. Okay, so this is for our online people, and follow those instructions. Okay, so obstructive sleep apnea, what is it? Each night we go to sleep, our body goes into certain stages of sleep, and in our stage 3 sleep, our body will get very relaxed. I mean, almost paralyzed. And when that happens, people whose airways are kind of tight and small may have a propensity to collapse on themselves, specifically at the palate and the base of tongue. And in this picture, you can kind of see a side view of someone's throat and face, and you can see where the back of their throat looks like it's very, very narrow and collapsed, and the air is trying to get in and it just can't get in. And in this picture, we even see a little tracing of oxygenation of somebody who may be in this situation where they are trying to breathe, but they can't because their body is so relaxed, it's literally collapsing. 20 million Americans, and potentially even more than that, have the severity of sleep apnea that really can impact their lives. And so this is the population we're trying to help. Next slide. So what happens when we stop breathing while we're sleeping? Well, it does a lot of things, actually. One, it disrupts how deep a sleep you get into. You don't get into that stage 3 sleep. Stage 3 used to be stage 3 and 4, by the way. We've combined them into one category. But it's that deep, restful sleep. You don't get into it. So you're constantly kind of in this hovering low level of sleep, and you're not getting rest. At the same time, you're going through these episodes where you don't breathe. And when you don't breathe, as opposed to other blood vessels in our body, our lungs will actually constrict their blood vessels. And the heart's trying to pump blood through these blood vessels that are constricted. And so your heart is working harder while you're trying to sleep if you don't breathe. Your brain is working harder while you're trying to sleep if you don't breathe. And your body is feeling the effects of this. And over time, people can get, you know, some of these really very, very familiar things to the people who have sleep apnea: fatigue, diminished productivity, snoring, hearing that obstruction occurring at night, potentially falling asleep at the wheel, heart and brain health. And I think, you know, some of the things that people probably it doesn't come straight to their mind is hypertension. So we have a lot of people who have hypertension that might improve after their sleep apnea is regulated, and headaches, other heart diseases. I've had patients who've had even potentially pulmonary venous hypertension. So there's a whole variety of things that the body is feeling when it's not breathing for periods of time while you're asleep. Next slide. So, you know, there's an interesting thing about this. When I lay down, if I laid down right here in front of you, I breathe just fine. But if I had, in my case, let's say too many drinks and I slept on my back, I might start snoring, could probably even potentially obstruct. So what's happening? Why am I having this problem while I'm asleep that I don't have while I'm awake? Well, while I'm awake, even though I don't think about it, I tense my tongue, I lift up my larynx, and I expand my chest, and I breathe. And I don't need anybody to help me do it. But if I was under sedation, or if I couldn't do that, I might start to obstruct. And that's what's happening to obstructive sleep apnea patients. So over the years, we've done things to try to take away the tissue in the throat and try to make it more open. And we found out it just doesn't really work. So then we came up with, well, okay, we can't cut it away. Let's blow it open. And that was a great idea. And that's called CPAP therapy. And it's probably the mainstay of sleep apnea. It's very well done, but it's a pneumatic stent. We're blowing open the airway. And anyone who tolerates that, it works great when it does. And I've had people hug me when they love their CPAP. And there's varieties types of CPAP. So there is auto-PAP, there's titrated CPAP, there's BiPAP, there's different types of CPAP. But taking that as a category as a whole, it's blowing open an airway that's trying to obstruct. So we are somebody in their great wisdom when they were coming up with this alternative treatment, the hypoglossal nerve stimulator, said, well, if you can just breathe while you're awake lying down, can't we just make a pacemaker for your throat that opens it up while you're sleeping? And so that's essentially the alternative that has been presented. So traditionally we had CPAP and it didn't work for everybody. In fact, only about 50% of people really tolerate it well, maybe even less, 50% in the beginning. So we've tried oral appliances, things that bring your jaw forward. See, if you're under anesthesia, we'll pull your jaw forward to open up your airway if you start collapsing because you're sedated. And the jaw prosthesis does that, but it puts a lot of pressure on the joints and people don't tolerate it so well. Their teeth start shifting. Then we did anatomy altering surgeries. And so we've talked a little bit about that. I have removed parts of the base of tongue, tonsils, palate, advanced the jaw, advanced the larynx, advanced the hyoid, sutured the hyoid, resected part of the jaw, and all those surgeries, eventually after months of being excited about them, I had years of being unexcited about them. They just didn't work for everybody. A couple home runs does not make a successful surgery. Next slide. So then came the alternative that I was discussing with you. Basically, a way of re-emulating your breathing apparatus, your airway when you're awake, when you're laying down, but this time having it work while you're asleep, while you're laying down. Sort of a pacemaker for your throat. And this is an example of how we would activate this prosthesis when it's in function. It's been implanted on this gentleman. He goes to the place of the processor that turns it on and turns it on. When he does this, a lead that's in the lung is sensing that he's breathing, and a processor called an IPG is processing that information and sending a signal to stimulate the nerve that controls your tongue. That nerve has some collateral stimulations, and the whole throat tends to just open up as that tongue starts to protrude and stiffen and move forward. And we're trying to isolate the branches of that nerve that stimulate the protrusors or the pushing forward muscles versus the retractors, the pushing back muscles. Because we have muscles that do both in our tongue. You know, some push food into our throat and some stick our tongue out. So this is how Inspire is able to open up your airway while you're sleeping during those moments that would normally obstruct. Next slide. It has, I think this is an interesting, a nice video that shows that it's really made a lot of headway in the media, and it's really come to the forefront. And that usually is grounded in success, not failures. So are we going to show that?
In our morning rounds, a treatment offering hope for millions of sleep apnea patients. The disorder causes people to stop breathing when they're asleep. An estimated 22 million Americans suffer from sleep apnea. It puts them at greater risk for diabetes, heart disease, stroke, and memory loss. Patients who are older, overweight, and male are generally most at risk. David Begnaud shows us the new option helping some patients. David, good morning.
Nora, good morning. For those who struggle with sleep apnea, treatments like the CPAP machine can be hard to sleep with. They don't always work, and a lot of people just can't get a full night's sleep with it. But now there's a new FDA-approved device called Inspire, and it's gaining popularity. For some people, it's a last resort. Their life literally depends on it. The Cleveland Clinic named this kind of treatment #2 on its list of top medical innovations for 2018. We met a woman who finally found
On CBS.
We'll provide you guys a link to the video. No, this is different. This is a woman who actually has this testimony. But you guys get me live. I'm kind of her.
You're gonna get a good testimony here.
Yeah, you got the real deal here. Okay.
Folks, for the online folks, there's actually a better local story, and that person's name is Lori Ledley. So,
Okay. So Ben, can you advance so that they're in the right spot? Sorry about that.
yes, do you want to restart it, or do you want me to advance?
We're gonna advance to the next slide, and we'll come back to that.
Okay.
So a safe outpatient procedure. This is an outpatient procedure. I would say most people do very well doing it as an outpatient procedure. Occasionally, I'll keep somebody overnight if they come in from out of town or they have other issues. But for the most part, people can go home right after the surgery. It's done through. It says 3 small incisions. It's really 2 small incisions now. We've been able to refine the technique so that there's less surgical intervention, there's less trauma, and so it really has made the recovery a lot better, as well as some of the recommendations after recovery. So pretty quick recovery. I can tell you, most of my patients will say that it was a breeze. There's always a few patients, everyone experiences discomfort different, but there's always a few patients that have a little bit of discomfort, but for the most part, it's been very, very easy to tolerate. It is a general anesthetic. The surgery takes, because of where we're going, it's a better surgery done under general anesthesia. You wouldn't really tolerate this under local very well. And not so much the chest part, although that probably could be done under local eventually, but the neck part, it would be very uncomfortable. We have retractors in there that is just not easy to tolerate while you're awake. So we're able to isolate the nerves to your tongue. That's called the hypoglossal nerve. Implant a device in your chest with a sensor lead into the muscles called the intercostal muscles that measure the respirations and breathing. And then we close those through 2 small incisions. You do get a little cut here and a little cut here, about 4 or 5 centimeters. Any incision in the first couple months, you can see it, but over time it hides and fades very well. Referring to this, it's got about 11-year battery. I'm thinking that generations in the future will have longer lasting batteries, but 11 years is quite a long time for most everybody.
Is that sensor external to the pec or?
The sensor is below the pectoralis. The processor is above the pectoralis muscle. So we have this implant that lasts about 11 years. At some point, the battery may have to be changed. This is not uncommon with some pacemakers that are very similar technology. It is MRI safe. You cannot have an MRI directly where that is. So basically the MRI of the chest is not allowed, and the shoulder, probably it's more important for the shoulder for most people. Most scans of your chest are done with what's called a CT scan. Almost never do they use an MRI. A few risks do we go through? A few risks to the surgery. Very small risks in my experience. A risk to the nerve to the bottom lip and to your tongue, and then a risk of air developing around your lung. All of those are brief, usually short-lived risks and treatable within the time of the risk of injuring your nerves to your bottom lip. It's a low risk. Where this implant is placed, the nerves are so close to their end muscles that even if you traumatize them and they were weak for a while, they'll usually grow back and work well again. You can do it on the side. In fact, we just did it on the other side a few weeks ago. I had a patient who had cancer on the right side of his neck, and I had done that cancer surgery, and he had radiation, which had made this tissue very tough. And I said, no way, I can't go through that tissue. I know I've been there before. He really wanted the prosthesis, so he did it on the other side, and it went beautifully. It went very well.
If you had to do an MRI side for a specific issue, on the other side.
You can't. It's just the way that an MRI works. It's circular around your whole body, so you can't really pick your side when it's happening. I will say there are other imaging modalities. Usually what I do is if somebody is seeing me about this prosthesis, I'm like, if you have any big shoulder issues, get your MRI right now. This is the time, and let's just get it done. So certainly shoulders can be an issue. Again, chest, almost always you're getting a CT scan. So it's really not as big an issue for that area. Spine, but usually the thoracic spine isn't a big imaging area for MRI.
If you're working out doing bench presses,
So the question is, if you're working out and you're doing bench presses, this.
Yeah, but your chest isn't going to disable it.
Yeah, no. So I guess if you slam this thing into your chest at the point of the actual implant, you could potentially do some damage to it. You would probably do damage to your ribs as well at the same time. You can eventually do all the exercises you would normally do, and including bench press. You'd probably be a little sensitive as to how fast and easy you drop that on your chest, which you shouldn't do anyways. As a bench presser, you would know.
Hey, Dr. Kelsch or Lori, we have an online question that relates to this. They're asking about a breast MRI, and I'm sorry to interrupt, but Lori, could you answer that real quick?
That is a good question.
Sure, because I'm a breast cancer survivor, and actually I was looking at getting Inspire for many years, and I kept thinking that my breast cancer history was kind of a deal breaker. And then it occurred to me when I actually had a little scare in my lungs, they put me in a PET scanner, and I was like, that's it. I'm treating my sleep apnea, because untreated sleep apnea will actually increase your risk of other things. And I believe my cancers, I've had more than one, were attributed to my untreated sleep apnea. So don't let MRI of the breast be a deal breaker for you. It's more important that you treat your sleep apnea.
And I apologize, I did ignore the breast MRI. That is definitely, my wife has had a breast MRI, so I should have had that on the top of my mind. Especially because they'll do the, so anyways, there are alternatives to imaging that area as she pointed out, including a CT PET scan. What was that question?
You can't put breast MRI in.
No. Anything from basically shoulder through abdomen area, MRI is not going to be available. Okay. Everything is removable. But the preference is definitely not to. This is not a surgery that you plan to be reversible, but everything is reversible.
Do you have a sleep study after you?
So we're going to get to some more of that in just a second. In fact, this next slide is all about that. So after we've implanted somebody and they've gone through the surgery, they've spent the night, they've gone home, there's a bit of a recovery. We have them do some neck stretching exercises. We have them avoid very heavy, rigorous exercise for about a month. They certainly want them to be active, but not, going on 10-mile runs. And for the first couple of weeks, for that chest area, we definitely want to limit their overarm and excessive arm exercises. But with our 2 incision technique, we haven't had to be quite as rigorous with our post-op recommendations. Then after a month, they get activated, and they will present to our activation team. And here's an example in the video of somebody needing to be activated. They're educated on their prosthesis. They're shown how to activate it. The device is tested, and then they go home and try it for the first time. And 85% of people, the very first, we've done nothing. The first time it works. There's always the ability to tweak and refine so that those people can tolerate it even better. But it's very quick for their first night to actually be successful using the device. The question is what's that?
Well, I didn't catch the last comment.
It's the first night most people are able to use their device the first night. The first night they activate it. In other words, you don't get activated. It's like, oh, we got to do about 25 more things before we get to do that. Sometimes there's some refinements, but for the most part, people get to use it the very first night with.
What is the step to activate it?
But you do have to wait a month to activate. That's correct.
What is the step to activate?
What's the question
What
again?
is the step?
Right here, touch this.
Okay, we're going to show you a video of the step to activate. So he is putting a monitor probe that's checking the device. And then he's showing him his device and how to activate.
Can you feel it in there, or is it?
So different people, different tissues. So the question is, can you feel it? I have a very barrel-chested, thin gentleman who I could feel the device very well. And I had someone who had a little bit thicker soft tissue covering who you're like, kind of, I think it's there. So it's different person to person. Certainly the thinner you are, the more these kind of things will be palpable. Okay. So there's a nice video on activation. We also, after we've activated, we will retest you with a sleep study to check to make sure that we had the, see what kind of result that we got.
Do a sleep study before.
You have to have a sleep study before the surgery. You have to have a sleep study within 2 years of the date of the surgery. So there was a study, the STAR study that looked at what kind of results we received. And they showed, it was in, I think, 132 people. They showed this result here that on average, they had a apnea-hypopnea index, which is how many times an hour that we stop breathing or decrease our breathing for 10 seconds. And the average person in this study was around 29 times per hour. And after they were implanted and followed up over time, up to 3 years, they decreased all the way down to 6.2. And actually the first reading was a little bit higher. It was at 8.7, and it continued to decline because their throats were even getting better over time. And that's kind of an odd concept. I told you this tissue is floppy, and people always say, why am I having worse sleep apnea as I'm getting older? Well, the more you're sucking in on that throat, the more soft and floppy and collapsible it gets. And over time, it actually gets worse. And we found the reverse is happening. When we stiffen, strengthen, and tighten that throat with your own muscles over time, you actually get better over time. Not in my practice, no. I order home sleep studies, and we do in-lab sleep studies that we order, and we work in collaboration very frequently with Valley Sleep Centers.
So do a sleep study. You have to be recommended for sleep studies. We're on advantage.
Sure. So the question is, to do a sleep study, you have to be recommended for a sleep study by somebody. And the truth is, it's not hard. Primary cares are astutely tuned to sleep apnea, almost to the opposite end of the spectrum. They're just like looking for it. So I don't think getting a sleep study is the hard part, although there may be some hurdles with regard to making sure you qualify insurance-wise to have the sleep study covered. And we do everything we can to make sure that you're a good candidate for the sleep study.
And if I could just interject really quick to your question. So at Valley Sleep Center, we have a full clinic where we have board certified sleep physicians meeting with patients in consultation and follow-up all day, every day in all of our locations. So you don't necessarily have to have a referral. You can just come straight to us. And we actually have Martha here for those of you online. You can
charge for that?
no, there's a charge. We do bill your insurance, and we'll check all that out and let you know. But yeah, I just wanted to let you know that we do the full clinic. You don't have to have an order. It's better if you come straight to us. We'll get it approved by your insurance. It's really difficult. It's very difficult nowadays for a family practice doctor to get a sleep study approved.
Yeah, I just came right to you guys.
Yeah.
So we come to you.
Yeah.
And you try to get.
Hey, Lori, for the live folks, can we press pause for the personal questions until the end if we can? So Dr.
Yeah.
Absolutely.
Yeah,
Sorry
we're
about
gonna
that.
pause
Appreciate
the
it.
questions until the end if everyone doesn't mind, because we've got all these people online we need to let go. We need to get him out.
Yeah. And then the follow-up to that is, well, everyone asks, do I stop snoring? And the answer is most people do. There is some people who continue to snore and make a noise. I have done surgery for snoring and sleep apnea for years, and I will have a wife come in and say, I can still hear him breathing. And I'm like, well, that's probably a good thing. But I get what she's saying. She's saying it doesn't sound like normal breathing. It's loud and it sounds like there's some airflow problem going on. But when we look at before and after Inspire, there was as it says here, 88% reduction. They went from 83% to 10%. It was something like an 80+% satisfaction on a soft snore or no snore patient. Next slide. So clinically proven. Patients like it, patients use it. 5.7 hours per night after their final visit and 94% positive feedback. Next slide. I would say it's definitely growing adoption. However, it isn't a surgery that everyone does. In our Valley, we have a good group of guys who are doing this. And that as the number of patients who've had great results become more, passed by word of mouth their experience, more and more people are coming forward saying, I've been on CPAP. I've thought if this is my lot in life, I'll just deal with it, and I'm looking for an alternative. Years of doing sleep apnea surgery and not being a sleep apnea patient myself, it's sometimes hard to have the empathy of what a sleep apnea patient is really going through. And so the people who don't sleep well, who wake up all night long, or who don't have that restful sleep and are really, really fatigued, this is a very poor quality of life for some people. It's not that bad for every single sleep apnea patient, but there are some who suffer dramatically. And to have an alternative to CPAP is a godsend for quite a few of them. So is it right for you? You have to have moderate to severe obstructive sleep apnea. You have to have kind of a range. There's a few check boxes for this to be a good candidate for you. You have to have an AHI between 15 and 65. So you have to meet specific numbers. You have to have the right anatomy. You have to have tried CPAP therapy. You have to be over, it used to be 22, it's 18. And then you have to have some anatomy in your airway that we think doesn't need to be addressed first and also meets the criteria for this. But it's quite a large group of people. It's actually most of the people that we see because they've already had their tonsils out and other things done in the past. So sorry to the online folks I tried to bring the questions to you, but I wasn't as good at it. Any questions from the online group or?
Yeah, actually, Dr. Kelsch, we've got a few questions. We're going to start off with a fun one. Someone wants to know, how tall is Dr. Kelsch?
6 something.
Everyone says 5'11" and a half and shrinking.
I don't know.
So I actually have a height board in my house for my kids, and we've been marking them. And mine's coming down, and theirs is going up. We're going to meet in the middle, I think, somewhere. So.
That sounds excellent. So someone wants to know, does insurance cover the surgery? I tried CPAP years ago with no luck.
Yes. So yes, insurance and Medicare covers this surgery. Medicaid, I believe, does not yet. And there are criteria so that we meet what the FDA set as the most successful candidates for this surgery, and the insurance companies and Medicare follow those criteria. And we have a very nice checkbox list of things that we march through to make sure that you meet all those criteria. And once you do, very rare that we don't get it authorized.
Excellent. Someone wants to know, and I'm not sure what they mean by this, does it affect body analyst scales?
Body analyst scales. So, maybe body mass scales. This is a very lightweight prosthesis. I believe the shell is titanium. I don't think that this is going to affect your body mass density or body mass index. There are body mass index requirements for you to be a candidate for the surgery. You have to be under 35 for Medicare and under 32 for commercial insurance.
BMI.
That's your body mass index. Correct. That's a height to weight ratio.
Somebody wants to know, Dr. Kelsch, they're asking how invasive is the surgery? I think they want to know inpatient, outpatient, how long does it take? If you can talk to that real quick, that'd be great.
Right. It's made through 2 small incisions. We don't remove any anatomy. We're only adding in a stimulator and sensors and this prosthesis for measuring that. The surgery is an hour to 2 hours. You wake up and usually are watched, because you have a history of sleep apnea, we'll watch you for an hour or maybe 2 to make sure you're doing well, and then you can go home. Occasionally, rarely, I'll have someone stay the night. And the recovery, usually the next day, they're feeling pretty good, up and walking, telling me how they doesn't feel like they had that big of a surgery. Certainly, I think over the next couple of weeks, you can get some kind of swelling and stiffness, as all incisions do. And so I try to meet those expectations so you kind of know what to expect. And then, but within a very short period of time, you're back to your normal activities.
Dr. Kelsch, someone wants to know, is there an upper age limit? You mentioned 18 plus.
There's no upper age limit. I would say, if you're 90 plus, I'm usually having a conversation about your other health issues and whether or not this is really a great option for you. I would definitely say 60s, 70s, and 80s. It's really that you are, that you're the right candidate, that you meet all those other criteria, that you don't have another health issue that precludes us from doing it. The higher you get in years, there's a little bit more likelihood that you're going to be on a blood thinner or some other thing that might have some bearing in our decision process, but there's no age limit.
Excellent. So this may be a Lori question. Someone sounds like they're a CPAP candidate and they need a new machine. Lori, do you want to answer that live or online?
So if you are a CPAP candidate and you happen to have a Philips machine that was recalled and it's over 5 years old, you qualify for a new one. So all you have to do is call Valley Sleep Center, 480-830-3900. There's people answering the phones right now, or I can reach out to you guys. Are going to all have my email after this is over. I can help facilitate appointments for anybody. And then again, we have Martha here live. So if you have a CPAP that was recalled and it's not 5 years old, you should come in and get qualified for a new one. And if you have one that's within 5 years, we have a link on our website where you can file the claim and we'll help you get a new one. So that's the answer to that. So thank you for a great question. All right.
Any questions in here?
If you're on blood thinners, obviously you have to go off.
Yeah, the question is, if you're on blood thinners, do you have to go off? And the answer is yes. That usually, I would include aspirin, yes. And even fish oil if you're on it. Yes, question.
Average sleep time, 5.7. What happens after 5.7?
So the question is what happens after 5.7 hours? Because the average sleep time was 5.7 hours. As we get older, some people do sleep less hours. In general, their ability to get into stage 3 sleep, even in an optimal situation, can be less. And then some people, lifestyle, I would say that that number is saying actually a lot of good. When you look at CPAP therapy people, sometimes it's a little bit shorter than that, where they're having a hard time meeting the criteria to keep their machine because they're not able to use it as often as the Inspire. So I feel like that's actually, to me, a very positive number.
Does this have anything to do with REM sleep?